In this video, I'm going to reveal the secret tips and tricks to easily remember the most confusing CPT guidelines from cardiovascular coding. These simple tips will help you crack most complex questions faster in the CPC exam. Without any delay, let's jump into the video and make cardiovascular coding super easy. Quickly like and subscribe to my channel. Let's get started. 1. Selective versus non-selective catheterization. Catheterization coding can be tricky, especially when dealing with selective and non-selective procedures. Here's how you can master it. A non-selective catheterization means the catheter is only placed in the main vessel and doesn't enter a smaller branch. Think of it as stopping at the highway entrance rather than taking an exit to a smaller road. A selective catheterization, on the other hand, involves advancing the catheter beyond the main vessel into a specific branch. Let's take an example: selective catheterization of the right middle cerebral artery. For this, the catheter first enters the right common carotid artery, then moves into the right internal carotid artery, and finally reaches the right middle cerebral artery. The key here: the catheter isn't just sitting in the common carotid, it's traveling deeper into specific branches. And remember this golden rule: a selective catheterization code includes the work done to reach that point. You don't separately code for the common or internal carotid arteries, they're included in the highest level of selection. This is where most coders make mistakes. But now that you know this, you won't. 2. CABG, coronary artery bypass grafting. CABG is a life-saving procedure used when coronary arteries are blocked. But are you coding it right? That's where things get interesting. The key to coding CABG correctly is understanding what type of graft was used. A lot of coders go straight to the number of grafts and pick a code, but the real trick is checking the type of graft first. If it's arterial alone, one code. If it's venous alone, another. If it's both, you need two separate codes. If only vein grafts are used, report codes 33510, 33516. If only arterial grafts are used, report codes 33533, 33536. If the surgeon uses both arterial and venous grafts, you must report two codes. 1. The appropriate arterial graft code 33533, 33536. The appropriate combined arterial venous graft code 33517, 33523. Here you need to understand the difference. There is no change in artery codes when used alone or in combination with venous graft. Only vein graft code change, depending upon used alone or in combination with artery. CPC examiners love to test this concept, so practice these code ranges thoroughly. In my CPC exam I got a question. I uploaded a video on 30k series questions. You can watch to know which type of questions are asked in CPC exam. Next topic 3. Pacemakers and defibrillators. Know the procedure first. Pacemakers and defibrillators are used to regulate heart rhythm, but the coding depends on 4 main factors. 1. What procedure was done? Was it a new device insertion? Was it just a removal? Was it a replacement? 2. What device was involved? A pacemaker? A defibrillator? 3. What was changed? The entire system? Only the battery, generator? Only the leads, wires? 4. What was the surgical approach? Transvenous, through a vein. Epicardial, open surgery. For example, if a patient has an old pacemaker battery replaced, you do not code it as a full pacemaker insertion. Instead, you pick the specific generator replacement code. This is a common area where CPC students lose points. They code the entire system when only a part was replaced. Don't make that mistake. 4. Interventional cardiology, stents and angioplasty. Now let's talk about stents, balloon angioplasty, and atherectomy, all procedures used to open up blocked arteries. Here's a quick cheat sheet to remember. If a balloon angioplasty was done, you code for angioplasty. If a stent was placed, you code for stenting and not angioplasty separately. If atherectomy was done, you code for the atherectomy procedure and not angioplasty or stenting separately. But here's where people mess up. If a stent and angioplasty are done in the same artery, you only code for the stent because it's a more complex procedure and includes angioplasty. However, if angioplasty is done in one artery and stenting in a different artery, then both codes can be reported. This is a CPC exam trick question, and now you know exactly how to answer it. The 5th guideline is endovascular aneurysm repair, EVAR. An aneurysm is a weak spot in an artery that bulges out. If it bursts, it can be life-threatening. Surgeons repair these using a stent graft, which is coded under endovascular aneurysm repair, EVAR. EVAR coding depends on 1. Which artery is being repaired? Is it the aorta, iliac, or thoracic artery? 2. How many stent grafts were placed? If more than one, you might need additional codes. 3. Was it done percutaneously or through an open incision? One common mistake in CPC exams? Forgetting to report additional stents separately. Always read the operative note carefully. If extra stents were placed, make sure you capture them in the coding. If you have any doubts in the guideline, comment below. So there you have it, the top 5 cardiovascular CPT guidelines you need to know. If you have any doubts, please comment below. If you found this helpful, hit like, share it with your coding friends, and subscribe for more CPC exam tips. Keep coding smart, and I'll see you in the next video.